Hello, everyone. Welcome back to Karan Academy. My name is Karan, and today we're going to be talking about chronic kidney disease. Now, this is a huge topic that is very common in our population today. It's one that you will almost definitely see on the renal wards, and I think is one you should understand quite well. So what is chronic kidney disease? As the name suggests, it's obviously going to be a progressive, and in most cases tends to be an irreversible loss of nephrons, which causes a global reduction in renal function. You need to know the stages of CKD, and this is often based on the eGFR. An important thing I'll mention here is you don't always have to have a drop in eGFR for it to constitute CKD. If you have a disease that you know is associated highly with CKD, like diabetes, and you have a patient with a normal eGFR, but they still have albuminuria or changes to their renal status, then this can still constitute stage 1 or premorbid CKD. Stage 2 is 60 to 90, then 30 to 60, 15 to 30, and then less than 15 will constitute stage 5 or end-stage renal failure. Now, I mentioned that patients mostly need dialysis or transplants when they come to stage 5 at this point. But as I mentioned as I talk about in our lecture on renal replacement therapy, a lot of the tools we use for dialysis, like arteriovenous fistulas, are surgical procedures that take not only time to perform, but also time to heal, which is why often if we know that their condition is progressive and degenerative, we might consider planning for these procedures while they're still in stage 4. We also actually never measure their true GFR. So we always use something called an estimated GFR, and this is based on their serum creatinine, as well as their height, their weight, and their obviously sex status. Because we only look at the serum creatinine, which is the only biological marker we look at, we don't look at urea, we don't look at anything else. Muscle mass is actually a big confounder for creatinine, and this is something you always have to consider when you are interpreting an eGFR or a kidney panel result. If you have two patients with the same eGFR of, let's say, 50, one of them is a really big bodybuilder, has tons of muscle mass, and the other is a 70-year-old frail woman, I would be much more concerned about the older woman because I know she doesn't have as much muscle mass, and therefore this high serum creatinine that has caused or that is shown as a low eGFR is more likely to be a better reflection or a more accurate representation of her kidney function than the bodybuilder who might just have a high serum creatinine because he has substantial muscle mass. And as you know, creatinine is a breakdown product of muscle tissue. So how does CKD actually happen? So we know a few causes, and the causes are here as well, but what's actually going on? In most of the cases, you have an initial insult to the kidney, right? So something's happened that's damaged the kidney from the early onset. What this often then leads to is a reflexive compensatory hyperfiltration. Now, why does that happen? Well, if you've shot one part of the kidney, you still need to maintain a high level of renal function. And this often leads to other parts of the kidney taking on that burden. And that hyperfiltration, although from a logical perspective seems to make sense because now your kidney might compensate for the damage, you need to know that this hyperfiltration over time is actually pretty detrimental. Because you are now filtering out, or you have way more volume passing, you tend to have dilation in the tiny pores of your glomerular capillaries. Over time, these pores grow in size and lead to the leakage of many inflammatory mediators like macrophages, neutrophils, and so on into the glomeruli. Now, this would not have happened earlier because under normal circumstances, those pores are small enough to prevent all those inflammatory mediators from leaking through, but that does not happen in this case. Over time, those inflammatory mediators cause further inflammation and damage, and you end up with scarring and fibrosis, and then that repeats because, again, you scar more tissue, the rest goes into overdrive yet again, and the same thing keeps happening. In terms of causes, I'd say you need to know at least the top 3 causes really well. So you have diabetes, that's the most common cause in Australia and most of the developed world. You have glomerulonephritis, or glomerulonephritis that we'll talk about in another lecture, and hypertension, so hypertensive nephropathy. The big thing that you see in hospitals that I've seen as well is when you have a patient with diabetes, the odds are that they also have hypertension. Now, how do you make that distinction, right? If you have a diabetic patient who has hypertension and now has CKD, well, is it diabetic? Is it hypertensive? In most cases, it tends to be a mixture of the two, but there are some important things that might distinguish one over the other. In order to develop a kidney-related issue from either one of these, they have to be present for a long time and they need to be significant enough. What I mean by this is, if you have someone who was diagnosed with diabetes 2 years ago and they have really good glycemic control, it is unlikely that their chronic kidney disease is going to be a diabetic one, even though they have diabetes. Similarly, if someone has hypertension for, let's say, 4 years, and it's sitting around the 130s with antihypertensive control, it's unlikely that the extent of kidney damage seen with their condition is going to be because of the hypertension. So you can use that to kind of have a rough estimate and know which one of the two it may be. But in most cases, you can't definitively make that decision. And it's often called just a mixed etiology CKD. It's not really relevant from a treatment perspective, but more so from an academic one. In terms of treatment, you would still treat them the exact same, and that does not differ. Let's talk about some tests, because you are always asked what tests you would order for CKD and how they kind of change in the disease, and you can memorize them. But here I hope to explain why you get certain changes. So you need to know what happens to vitamin D, calcium, and PTH levels in CKD. Now, this is a big one, comes up in endocrinology a whole bunch. You'll be asked this on the wards, so it's good to know. Vitamin D, it increases calcium absorption in the gut, and it undergoes first pass activation in the kidneys. Obviously, that first pass activation is not going to be happening with CKD, and therefore you're not going to be able to absorb as much calcium. So you have low vitamin D, which would lead to low calcium absorption because of the CKD. That's one point. Secondly, you also need to know how phosphate changes. So we tend to have more phosphate in the blood. This is just because you aren't able to excrete a lot of it out because you have CKD. Phosphate has a tendency to bind to calcium. And when it binds to calcium, it inactivates it. You need to know that calcium is present in two forms. You have ionized calcium and you have unionized calcium. The only part of the entire calcium composition that is active and does something in your body is going to be the unbound or the ionized part. And that's the important bit. It doesn't really matter if you have tons of normal calcium. It has to be unbound for it to be metabolically active. So what's happening here? So you have more phosphate in the blood because you aren't really excreting it, and that further binds to more calcium and inactivates it. So now we have two things that have happened to calcium so far. First, we have an overall lower level because vitamin D is dropping. And now secondly, we have whatever was circulating around has now been partly inactivated by the extra phosphate. So your body is going to detect, oh, well, I don't have a lot of metabolically active calcium. I need to get that up. Now, how does your body increase calcium or its serum calcium? By parathyroid hormone, PTH. So you end up with increasing the levels of PTH to increase the level of calcium. And this is called secondary hyperparathyroidism. Over time, because this issue is progressive, you're still going to be having high levels of phosphate. You're still not going to be absorbing calcium. This is probably going to be a progressive issue. And over time, as you drain more and more calcium out of the bones, you're going to end up with osteoporosis, which is why osteoporosis is a common complication that you need to look out for in chronic kidney disease. Often, once your PTH levels have been high for so long and your PTH undergoes hyperplasia, you can end up with a hypercalcemia, actually, where you overshoot the calcium, causing an overall hypercalcemia. This leads to two things. It leads to vascular calcifications seen in the aorta because now you have too much calcium, and that predisposes you to further plaques and ruptures and whatnot. And then secondly, you have an increased tendency for nephrolithiasis or kidney stones because your body is going to try and excrete that calcium somehow, and that's going to accumulate in the kidneys and cause kidney stones. Something very similar happens with androgens, which are activated in the kidneys. So in the lack of that activation, women can end up with amenorrhea because of their CKD. You can also get EPO deficiency, as you know, that's secreted by the kidneys, EPO or erythropoietin, that can cause an anemia. That's going to be a normocytic anemia. Because you're not excreting water as well, you're going to end up with hypertension because you have too much fluid. And this is again tricky because you can have hypertension that causes CKD, but you also now have CKD that causes hypertension. Another interesting complication. You can have APO or acute pulmonary edema, as well as peripheral edema. Again, you aren't going to excrete potassium as well. That's going to lead to arrhythmias. And if you have too much urea, that can lead to uremic encephalopathy, which is characterized by a uremic itch, a uremic flap, as well as encephalitis. So how do you remember all this? A good acronym is a wet bed. So A for acid-base issues, accumulation of waste products, EPO deficiency, buildup of toxins, high blood pressure or blood pressure, electrolyte imbalances, particularly hypercalcemia and hypercalcemia and hyperkalemia. And then you have D or vitamin D deficiency. Now moving on to how do you manage CKD? Now this is going to be a bit tricky because CKD itself, as we talked about, has a lot of causes. And our first thing we're going to do is try to identify a cause, if we can, and treat that cause. So if they have diabetes, good diabetic control, regular checkups. If they have hypertension, getting them on their antihypertensives. If they have a glomerulonephritis, treating it with immunotherapy. Apart from that, we would be looking very closely at their cardiovascular risk because cardiovascular disease is actually the leading cause of death in CKD. It's not the kidney failure, it's not the dropping eGFR, it's not the uremic encephalopathy, it's cardiovascular risk and heart attacks and cardiovascular events basically. So we want to maximize their blood pressure control, this starting off with ACE and ARBs, which have been shown to be renal protective, and they tend to reduce the degree of proteinuria. So they're really good to use in CKD. Good control of blood sugars, lipid management, which would usually involve starting them on a statin, as well as aspirin. You can also go for more aggressive anticoagulation based on their cardiovascular risk or if they've had previous clots. Additionally, we want to give them what they can't make. So EPO injections to ensure they're not anemic, vitamin D supplementation and calcium, because again, they're not going to be converting or activating vitamin D. And you know that vitamin D helps absorb calcium. So we want to give them more calcium as well sodium bicarbonate to prevent some of the acid-base disorders we talked about. Lastly, we want to manage their fluid status. So we want to ensure that they are fluid restricting to 1 to 2 liters a day. This is also because they're not going to be filtering out and excreting water as much. So we don't want to overburden the kidneys even further. And if you have complications like peripheral edema, APO, we might consider giving them furosemide because we know that helps. Lastly, once they move on to end-stage renal disease, which is usually your eGFR around 15 or less than 15, you would be starting to consider renal replacement therapy. And you have 3 different forms. You can go for hemodialysis and hemofiltration, which is typically more effective, but needs to be done in hospital. It can cause hypotension, and they would usually have to come in about 3 times a week for this. The next step up, or another thing you can consider is peritoneal dialysis. Now, peritoneal dialysis works on the same principles of hemodialysis, and I talk about this quite a bit with our renal replacement therapy lecture. It's less effective, but the good thing about it is that it can be done at home. They don't have to come into hospital, and I guess it's just easier to do. It does run the risk of peritonitis because you are inserting a catheter into the peritoneal cavity, and that can lead to spontaneous bacterial peritonitis, which is not good. And it's contraindicated in diabetes because they have a already increased risk of infections. Lastly, we have renal transplants, which are the best option, obviously very hard to organize, and they need to be considered in stage 4 because there's a long waiting list and immunotyping, and you have to undergo a whole bunch of testing for different compatibility markers, serology, and so forth. So we try to plan this as ahead as possible if we can. And the 10-year survival rate for renal transplant is 60%, which is relatively good considering that most of CKD does present in older age groups. That's all we had for CKD. Thank you guys for coming. As always, any questions, shoot me a message. And please look after yourself and please look after your loved ones.